The quick question becomes, well, who is a candidate? How do you decide who might be appropriate for this type of operation? I have three criteria. They're relatively straightforward. First of all, you have to have good history for a pinched or irritated peripheral nerve in the head and neck causing your symptoms. So in my practice, the patients have to have been evaluated by a neurologist or GP with a specialization in headache medicine. They have often failed pharmacologic therapy with multiple agents from multiple medication classes. They failed multiple non-operative therapies, as you've seen earlier. Obviously, depending on the area, it's more relative or more relevant than in others, but certainly for patients with temporal pain, you have to have negative imaging studies so you rule out other organic intracranial pathologies such as acoustic neuromas or if they have bruxism, TMJ disorders. And I think one of the important things to point out, as Nicole Lindberg said in her previous talk, these patients have to have significant impairment. So when you really sit down and drill and talk to these patients, these are not people with 6 or 7 really bad migraine or headache days per month. These are people often who have pain 24/7, and what they term a good day is when the pain is only a 4 or 5, and what they term a real bad day or migraine day is when that pain gets turned up to a 9 or 10. Criteria 2, good physical exam for peripheral nerve compression or irritation causing your problems. And I submit to anyone I will ever talk to that much like you can look for a positive Tinel sign over the median nerve at the carpal tunnel in a patient with carpal tunnel syndrome, you can find similar findings in patients with, for example, occipital neuralgia that have been misdiagnosed as migraines, which I believe are chemical abnormalities as opposed to these neuralgic issues, which are mechanical problems. Patients will have local pain and tenderness on palpation, often dysesthesia to light touch. A lot of these patients who are women will say, my hair hurts. I hate to have my hair up in a ponytail, so I just don't wear my hair the way I like to most of the time. They should have no restriction in their head and neck movements, no ongoing active neurologic abnormalities. And psychiatric abnormalities is a relative contraindication, hence the question mark. I think the important point there is that a lot of these patients have anxiety and depression, perhaps as a result of the chronic pain disorder, some of which is pre-existing. But of course, whenever it comes to pain or dysesthesia, patients have to be able to communicate effectively and consistently with you how they're doing both pre as well as post-operatively so that you're able to very effectively and accurately assess whether your intervention has had any real benefit. And the third criteria I use, the patients have to have a good response to nerve blocks. I often say to my patients, I literally want you to present to the office in as much pain as you can be in and still walk through the door. And if they come in with severe, horrendous occipital discomfort and we block sequentially the greater, lesser, and or third, also known as the least occipital nerves, and the pain goes down incrementally, we now have potential surgical targets. And if you meet these criteria, you're a good candidate, in my opinion, for surgical intervention. So now the question is, well, what the heck is it that we do during these operations?